I'm the Vice Chair of Education in our department, Sandrine van Schaik, and I'm welcoming everybody on behalf of Dr. Hirsch, who couldn't be here today. We have two very special speakers today. It's not very often that our grand rounds are co-presented by a person who's still in medical school, but today is one of those special days, and we're really excited to have her, Dr. to be Rita Sachidanandan, and Jeanette Lager. Jeanette Lager is a colleague of mine who does a ton in education. That's how I know her quite well, and is a professor in the Department of Obstetrics and Gynecology. They have come to this project because it all started with Rita's experience with endometriosis and her exposure to others experiencing gaps in menstrual care. She met Dr. Lager, who has expertise in the area and passion for education towards improved patient care. And so a little bit more about Rita. Rita is a first-year medical student at UCSF. She's a coordinator for the OBGYN and psychiatry student interest groups and is passionate about learning how to serve vulnerable populations through advocacy and education. She has had the opportunity to present a similar talk at hospitals in the South Bay, as well as conduct menstrual disorder clinics at a local pediatric office where she developed a love for patient education. Dr. Jeanette Lager provides clinical care in gynecology. Caring for women is really her passion. Dr. Lager provides patients with an array of treatment options tailored individually to each patient, and she specializes in minimally invasive clinical and surgical procedures for the treatment of abnormal uterine bleeding, adenomyosis, fibroids, endometriosis, and benign ovarian cyst, among other conditions. She has a career interest in medical education. She teaches surgical skills to medical students and residents in both the lab and in the operating room. She's the director of medical student education at OBGYN, overseeing medical student education over the 4-year curriculum, and regularly lectures to medical students on various topics. She's also the clinical clerkship director for OBGYN in the School of Medicine. Her nonprofit work is dedicated to maternal and child health. Since 2008, she has been on the medical advisory board of One Heart Worldwide, a nonprofit organization focused on improving maternal and child health care for indigenous populations in developing nations such as Tibet, Nepal, and Mexico. And with that, I'm handing it over to Rita and Dr. Lager.
Great. Thank you so much, Sandrine. I'm just going to get ready to share my screen. There we go. Perfect. So thank you all for coming to this lecture today. We're going to be talking about dysmenorrhea and endometriosis. And just to provide an overview, we're going to start with a case. Rita will be starting with the case we'll be talking about. We'll go over the definitions of dysmenorrhea, endometriosis, and chronic pelvic pain, talk about specifically the pelvic exam for pelvic pain, the pathophysiology, management outcomes, and then next steps in thinking about perhaps a UCSF Adolescent Endometriosis Center.
Thanks, Dr. Lager. So as Dr. Lager mentioned, throughout this presentation, I will be presenting portions of a case. And this patient case is actually very close to home because it is, in fact, my own case and my own experience with dysmenorrhea and an eventual diagnosis of endometriosis. As far back as I can remember, I've been experiencing extreme pain with my periods, as described on this slide, pretty much 10 out of 10 cramping pain. And there were often times when the pain would be so bad that I could not make it to school that day, and I found myself confined to my bed and essentially incapacitated. And after a couple years of having my period, I was at a well child visit with my pediatrician, and I mentioned the symptoms that I had been experiencing to her. And after asking several follow-up questions, she had turned to my mother, who was present in the room with me, and asked if she had experienced painful periods as well, and whether or not she was ever diagnosed with a menstrual disorder. And my mother replied that she had experienced very painful periods. However, she was never diagnosed with a menstrual disorder. And my pediatrician then mentioned that it was likely that my pain was hereditary, something that I had inherited from my mother, and that I could take ibuprofen with any extra pain that I was experiencing, and otherwise I should be good to go. And an important point that I just wanted to bring up with regards to my case is that my mother actually immigrated to America from India over 30 years ago. And she has mentioned to me since that pain is almost part of the culture there. It's not something that's necessarily discussed, much less brought up to the physicians. And she mentioned that it was very unlikely that with speaking to her physicians about her symptoms, that she would have received appropriate follow-up. And that essentially left my pediatrician with what was an incomplete family history. And the reason why I bring this up is because I believe this may be a shared experience with other adolescents in this country, as many of us have family who have immigrated from nations across the world. And even within America, there are many vulnerable populations, specifically people of color, who are typically underdiagnosed with menstrual disorders and can have varied follow-up and appropriate treatment. And with that, I will hand it back to Dr. Lager.
Great. Thank you so much, Rita, and thanks for sharing your story. I think that it's really helpful to get your perspective, and we'll continue to weave her case into the talk. So pelvic pain, as you know, is pain that's located in the lower abdomen, and it can be related to GYN organs, but of course, you know, it can be related to either GI or urinary symptoms. We differentiate acute pain from chronic pain as less than 6 months or more than 6 months. Chronic pain can be either constant, intermittent, cyclic, or acyclic, and the differential diagnosis can be very broad. Dysmenorrhea is the most common menstrual problem for adolescents. It's generally primary dysmenorrhea, so in absence of any pelvic pathology, and usually occurs when adolescents attain ovulatory cycles, but that's not always the case. And it can be a little bit more irregular or non-cyclical in adolescents, especially because they don't necessarily have ovulatory cycles when they first begin having their periods. Secondary dysmenorrhea is painful periods that can be related to pelvic pathology or a medical condition, and endometriosis, especially in adolescents, is the leading cause. It occurs in about dysmenorrhea occurs in 50 to 90% of adolescents. It can cause them to miss school, and 12% of adolescent patients that are between 14 and 20 years of age had lost days of school because of dysmenorrhea, and almost 1 in 4 self-administered pain medications without seeing a physician to investigate the cause of their pain. We do know that adolescents have an even longer delay in diagnosis than adults, and that may be as a result of not coming in self-treating as well. As you likely know, endometriosis is a condition where endometrial glands are located outside of the uterus. They can cause pain with periods, pelvic pain, pain with intercourse, sometimes infertility, and depending on where the endometriotic lesions are located, may have pain with bowel movements or urinary symptoms as well. An unusual, less common cause or presentation can be shoulder pain related to diaphragmatic endometriosis. As Rita had mentioned, as we're talking about family history, there is an increased incidence in first-degree relatives. It may be due to multiple hits within the target genes, and some studies have shown that there are at least 6 genomic regions that are statistically associated with endometriosis, and that we've seen somatic mutations in many of the deep endometriotic lesions. There are several different theories for endometriosis. The most common one is retrograde menstruation. However, it is thought that it may be embryologically derived or may be associated specifically with the endometriotic lesion, that pro-inflammatory factors can increase the pain and cause either peripheral nerve issues or centralized nerves. Okay. When we evaluate patients, we do very similar to what you would usually do to evaluate the patients, including their history, exam, and then I'll talk a little bit more about pelvic imaging and diagnostic laparoscopy. So it usually can be early, although it may not be with their first ovulatory cycle. So for adolescents, they may start having the pelvic pain quite early. We like to know about gestation and parity, although that's less of an issue with adolescents. Most desire future fertility, and usually we're not talking about infertility, but sometimes when patients have had severe pelvic pain for a long period of time, even in the adolescent stage, they often talk about more extensive treatments like hysterectomy, which I definitely deter people from pursuing, especially in adolescence, as they may not have made any decisions about fertility at that point. And then, of course, taking the history of their pain. It's always helpful to know what treatments they've been doing in the past and specifics of their surgeries. I'm always interested in seeing what they found at the time of their laparoscopy. If they have laparoscopic photos, it can be very helpful. And as we'll mention later, the lesions on in adolescents can be quite subtle, so may sometimes be missed. You know the exams quite well, but I think one of the things that can be helpful is to do a single finger digital exam. If you indeed decide to do an exam in adolescents, especially if they've never been sexually active before, sometimes the history can be the most important part and may not necessarily do a pelvic exam as the next step. But if we do an exam, usually I'll do a single finger digital exam, and that allows to examine the muscles, checking the levator muscles, obturator muscles, and piriformis to see if that is a component of their pelvic pain. Often if the patient's had a pelvic pain for a long time, there's usually a component of that. And we'll talk later about pelvic floor physical therapy, for example, that can be very helpful for that. Other things to consider is if they are sexually active, to do STI screening as well. If a patient does have progressively worsening dysmenorrhea, kind of like Rita had mentioned, where NSAIDs are not enough, that they're missing school due to the pain, then I think that is a reason to evaluate with imaging. We often start with a transabdominal, transvaginal ultrasound. Although lesions are often not seen on ultrasound, we'll see ovarian cysts, for example, on ultrasound, but it wouldn't evaluate for often areas of deep endometriosis. We've been working very closely with the radiologist, and so they have been very good at diagnosing deep infiltrative endometriosis on MRI. And so the MRI gives us an opportunity to evaluate any areas of deep endometriosis. If they see, for example, bladder lesions, thickness near the uterosacral ligaments, all of those can suggest endometriosis, while at the same time also looking and identifying an ovarian cyst. This is just a couple of examples of some of the MRI images. As I mentioned, most of the ultrasounds can be negative, even if the patient does indeed have endometriosis. But if a patient does have an endometrioma or an ovarian cyst on imaging, then they have a 5-time increased risk of having a obliterated cul-de-sac or more extensive endometriosis. If you look in these images, the arrow is basically pointing where there's in A, you can see there's a little bit of thickness that is just lateral to the uterus. The uterus is in the central area. And so they'll look at either the round ligament, the uterovarian ligament, to see if there's areas of thickness based on the T1 and T2 images. They'll look in the rectovaginal junction to see if there's thickness in that area. And then sometimes if it does look like they have a bladder lesion or a bowel lesion, then it can be helpful to also use rectal or vaginal contrast, and that will allow them to look carefully at the rectovaginal junction. That can also be traumatic for some patients though. So it may be beneficial to just start with the MRI alone, although some patients you can pre-medicate them as well. But I do think that particularly if we're looking in that area, it can be helpful to do those additional contrasts. For treatment, goals of therapy is to help them with their symptoms, to suppress disease progression, and of course, generally protect fertility. And I think that one of the reasons why it's helpful to know what their previous medications and treatment have been is that it helps to get an idea of what the best treatment is for them based on their need for contraception, as well as patient choice. So back to the case.
Thanks, Dr. Lager. So a bit more about my case. After the initial visit with my pediatrician, I began taking ibuprofen whenever I was experiencing pain on my period. However, I found that the pain was getting worse. It was not really responsive to the NSAIDs. And I had a new onset of nausea around the time of my period, as well as extremely painful bloating that was occurring at random times. And I never thought to bring these symptoms to my pediatrician. I never once in my mind associated them with my period whatsoever, and simply assumed maybe it was something I ate, essentially not something I brought up at the time. And I had also assumed that the pain that was occurring, if it was something that was hereditary, was just something that I had to deal with. And on the next slide, I can, oh, sorry, thanks, Dr. Lang. During my freshman year, during my finals week of my freshman year of college, I was having dinner with a friend in the cafeteria, and I began to experience what I could best describe as abdominal discomfort and wooziness, which was the appropriate medical term that I used to describe it to my doctor. And I assumed that this was something with relation to my period, and I attempted to return to my dorm room, which was just across the street. However, I was unable to make it. I collapsed on the sidewalk outside of the cafeteria and momentarily lost consciousness. However, I was able to get in contact with a friend who took me back to my dorm room and helped me get situated. And even at this time, I did not believe that my symptoms were important. I actually did not want to go to the emergency department because I thought that I would be wasting important people's time and resources. And it was my friend who urged me to go ultimately. And even after getting to the emergency department, it was only when my physician prompted me and he had asked me, you know, have you ever been experiencing any symptoms such as nausea or bloating or anything else that I should know about in recent history? And that was when it kind of a switch hit in my head, and I realized that, you know, I was experiencing nausea, especially around the time of my periods, and bloating that had happened more recently. And I was eventually wheeled in for an abdominal ultrasound. And even at this time, I truly thought I was wasting the technician's time until the ultrasound probe went over what I now know as the area of my right ovary. And I could see his face change immediately. And I was begging him to let me know what was going on, but of course he couldn't tell me. And eventually my physician told me that I had a cyst on my right ovary and that I needed to meet with a gynecologist as soon as possible for follow-up. And the details of that are on the next slide. I did not have a gynecologist at the time. I really did not have an intention of seeing a gynecologist, really for far into the future. So I kind of scrambled to find one, and we had an initial appointment during which she requested a transabdominal ultrasound, as well as some blood work and an MRI to evaluate the situation and see what next steps would be. And as you can see on this slide, the ultrasound, or sorry, my apologies. This is the ultrasound from the ER, actually, and that showed a cyst. And yes, this torsion was ruled out. I was given a bit of pain medication and sent home to find a gynecologist. And on the next slide, the second ultrasound that I had showed an avascular, well-circumscribed hypoechoic mass on my right ovary as expected. And I think they had mentioned to me that it was about 8 centimeters large, which was 8 centimeters, which was large. And I did not have a pelvic exam conducted because I was not sexually active at the time. However, a normal like abdominal physical exam was conducted. And on the next slide, there's some information about my blood tests. These were essentially normal, except for, I think it was cancer antigen 125 that was slightly elevated. And on the MRI, the same lesion was found to be consistent with an endometrioma, and there was evidence of endometriosis in the cul-de-sac. And I want to just mention that at this time, I had no idea what endometriosis was. There was a little bit of exploration on WebMD, which I can guarantee did a bit more harm than good. But I will now pass it back to Dr. Lager.
So based on these findings, you know, she definitely had an acute exacerbation of her endometriosis and had failed medical management thus far, although she really had only been doing NSAIDs until that time, with this very, very short period that she had tried birth control pills for less than a month or so. She, as you know, she had the sudden onset of acute abdominal pain, which always puts in our differential diagnosis torsion, although it's pretty unusual for an endometrioma to torse, although they can, but because of endometriosis and just the nature of the condition, they tend to be a little bit more sticky, so less likely torsion. But given its size, it certainly could have torsed. They ruled that out in the emergency room, of course, and then did tumor markers, which were negative. She mentioned her CA-125 was elevated, which we often see in endometriosis. So any young woman, we wouldn't necessarily order a CA-125 or tumor markers if it appears that it's a benign cyst that's consistent with an endometrioma. And then after they counseled her on a diagnostic laparoscopy, ovarian cystectomy, and then an excision of endometriosis. What they reported in the operative report is that there was an 8-centimeter mass that came emanating from the right ovary, that it was adherent to the uterosacral area and contained chocolate colored fluid, which is grossly typical of an endometrioma. They did do a frozen section, which was benign as well, and then noted that there were implants in the cul-de-sac, uterosacral area, and the anterior pelvic surfaces. All of those areas were treated. We do always try to take a look at the appendix because there are sometimes that will note endometriosis on the surface of the appendix. And in those cases, we would do an appendectomy as well. And the contralateral tube and ovary were completely normal, and the uterus was normal. These are just the images from that laparoscopy at that time. So you can see in the imaging on the right side, the large ovarian mass that's basically central posterior to the uterus, which is quite characteristic. And then there are the gunpowder lesions, or the dark lesions that are noted both posterior to the uterus and left of the ovary along that uterosacral ligament. And then if you look at the image on the left, that's anterior to the uterus, so near the left pelvic side wall and near the bladder. Postoperatively, she was put on continuous oral contraceptives and NSAIDs Purine.
So just a bit more update about where I am in my treatment now. As Dr. Lager mentioned, I am currently on a combined estrogen progesterone pill, as well as NSAIDs for any pain. I am very happy to report that my nausea is very rare nowadays, and I do experience some painful bloating. And it is occurring at a slightly greater frequency. But other than that, I am doing well. And when reflecting on my case, in my humble opinion, I believe that there are certain steps that my pediatrician could have taken that would have supported me throughout this process. And primarily, I had the opportunity to look back at my health records from the time in preparation for this talk. And I noticed that the diagnosis of dysmenorrhea was actually never never mentioned anywhere in my health record. And I think one of the reasons why this might have been a bit helpful for me to understand that term and how it applied to me would have been within the context of knowing that this pain was abnormal. But most importantly, I think understanding that there were symptoms such as nausea and bloating that could be indicative of further complications. And it is possible that in the months leading up to my visit to the emergency department that I may have checked in with my PCP, given that I was 19 at the time, with regards to these new symptoms that I was experiencing. And so that would have been a portion that I think would have been helpful for me. And because Facebook is always listening in on me and tracking my activities, I have, since the time of my surgery, been referred to a variety of endometriosis support groups on the platform. And I've noticed a lot of women commenting very similar experiences to me, that they had early presentation of various symptoms and delayed follow-up in the future with some sort of exacerbation, not just in relation to endometriosis, well, although these were endometriosis support groups, but even discussing conditions such as PCOS and fibroids and other such conditions. And that prompted me to actually conduct menstrual disorder clinics at a local pediatrician's private practice, in which we discussed problematic symptoms that young women might face during their periods with patients, and the importance of bringing these symptoms to the doctor's attention to receive any necessary follow-up. And during one of these conversations, I remember speaking to a young girl about, these are these symptoms, there's nausea and bloating. And I was very lucky to have that experience myself, that I was able to honestly explain my own process to these young girls that, hey, I had this too. And this one girl had mentioned to me that she had been experiencing these symptoms throughout all of her periods. And she said, I thought that this was normal. Everyone told me this was normal. And I found myself replying to her, well, so did I. I totally thought this was normal. I completely believed that all girls were just meant to have pain during their periods. But it wasn't. And we were able to follow up with her. And I think that emphasizing these problematic symptoms and having that component of early patient education is something that I believe is instrumental for helping these young girls and young people with ovaries to receive the follow-up that they need. And I will pass it back to Dr. Lager.
So thank you, Rita. And I think that, we're so lucky because we have such great pediatricians here that do a lot of preemptive counseling on this. And, I think that, Rita, you bring up a great point, which is, it's normal to have dysmenorrhea. It's incredibly common to have dysmenorrhea in adolescents, but when it disrupts one's life and they start missing school, and all of that, then I think that it's important to manage and offer different treatments. So of course, NSAIDs can be first treatment, and there is not any clear superiority over one NSAID versus another. So usually the main thing that I'll check is to make sure that they're taking an adequate amount of whichever NSAID they're taking, and that it's usually most effective if they started a couple of days before their periods, so if they're tracking their periods, which can be helpful also for tracking their pain, almost like a pain diary as well. I think that can be helpful so that they can kind of preempt their periods, treat with NSAIDs, and then continue it throughout the beginning of their periods or throughout the whole period, depending on what their symptoms are. And then to make sure, of course, to take it with food, and that if one agent doesn't work for them, they can always try a different agent. I just wanted to add a note on opioids in adolescents. that opioids, are sometimes prescribed if the pain medications are not working, but I'm sure, as you probably know even better than I do, that children can develop a dependence even quicker sometimes than adults, and that when someone is on opioids for a long course of time, it can also cause hyperalgesia, which then leads to even more chronic pain. So because of all of these reasons, it's great to think of other treatments prior to opioids, including hormonal medications that we'll talk about, and then also considering other non-opioid pain medications. Hormonal agents are really the mainstay and can be for dysmenorrhea, primary dysmenorrhea or secondary dysmenorrhea. And I think that there has been a trend moving towards clinical diagnosis of endometriosis, just so that we can treat it sooner, since there are some symptoms that are quite characteristic for endometriosis and can avoid the need for surgery, although there is a role for surgery for some patients starting out with hormonal medications if NSAIDs are not adequate or they're not a candidate for some reason. And so really any form of hormonal treatments can be helpful. We usually start with combined oral contraceptive pills that can be taken either continuously, especially if they have quite a bit of pain during their menses, or they can take it cyclically. It helps to create a hypoestrogenic state in the endometriotic lesions. Also, progesterones can be used as well. So that could either be the IUD, so progesterone containing IUD, Skyla, Kylena, Mirena. All of those can help with symptoms of dysmenorrhea and pelvic pain. Oral progesterones, Depo-Provera, Nexplanon, any of the forms of progesterones can be helpful. And it depends really on the patient's needs and what their priorities are. If they have difficulty taking a pill, for example, then some of the other forms may be helpful. Also, the vaginal ring can be used, and it can be used continuously as well. It has 4 weeks worth of hormones in it, so that they can just change it every 4 weeks. Other hormonal agents include gonadotrophic releasing hormones, agonists and antagonists, so leuprolide or Orilissa. Usually, I recommend starting with a hormonal medications like birth control pills first, just because there are side effects related to these. Both of them can cause hot flashes. It can affect bone loss. I recommend doing add back, and that can be done from the beginning with the medication. So using leuprolide and then norethindrone as well for add back, that will help with the hot flashes. And then the other thing that's important is Orilissa is not a contraception, or contraceptive. Neither is leuprolide, so we just need to ensure that if they are sexually active, that there is some sort of contraception that they're using. Other medications include medications that address centralized pain and hyperalgesia, so gabapentin, Lyrica are both great non-opioid pain medications. And usually I'll counsel the patients about how, that they're definitely feeling pain and experiencing pain, but the way it's processed centrally in the brain, that it amplifies the response to touch or pain, so that they're having even more severe pain associated with this pelvic pain. There are many different complementary therapies, and I think it's really patient dependent. Some work better for certain patients than others. There's limited data on exercise and heat. There is some limited evidence on dietary supplements. Some people will use TENS units, acupuncture, herbal preparations, and yoga. They have all shown improvement in some studies, but the safety and efficacy of herbal treatments are unclear. We work closely with the Osher Center, and there is an integrative medicine gynecologist, Dr. Cuneo, who sees patients and can help a lot with mind-body techniques for pelvic pain and endometriosis. And then, of course, they have resources for acupuncture as well there. Surgical approaches, always it's important to just consent them, help the patient have expectations of what they will achieve from surgery. Some patients, if they failed medical therapies or they're reticent to try a medical therapy until they have a definitive diagnosis, that can be one of the reasons why we would move towards surgery. Also, if they've tried the medical treatments, still continue to have pain, then we'll often talk about diagnostic laparoscopy and possible excision of endometriosis versus operative or radiological findings. So usually the treatments of combined oral contraceptives will not shrink down an ovarian cyst or an endometrioma. So ultimately, they often do need surgery to remove the ovarian cyst if they have pain associated with that. We do talk about a multidisciplinary team approach when it comes to surgery, especially if they have other components of pain that could be improved. So occasionally, especially if someone has a lot of pelvic floor muscle spasm, I recommend that it's important for them to do physical therapy, specifically pelvic floor physical therapy prior to surgery, because they can sometimes have even worse pain after surgery because their muscles tense up even more. So have them see the physical therapist first to help with relaxation techniques and things that they can do post-operatively as well. And then also to reinforce to patients that if there are other components that are related to the pain, such as either the pelvic floor or let's say they have interstitial cystitis or IBS, that all of these things are addressed and that we're working together to help improve their pain overall. Because even if we improve the endometriosis pain, they may still have these other concurrent issues that are contributing to the pelvic pain. There are many different ways that we treat endometriotic lesions. It can be excision, so excising the area surrounding the lesion, ablation or heating up the lesion or burning the lesion, taking down the adhesions, and then ovarian cystectomy. Generally, the recurrence rate of an ovarian cyst, if it's drained or the cyst wall is not removed, is quite high. It can be as high as 80% that the cyst will recur. So generally excision of the ovarian cyst wall is important. And rarely do we need to do an oophorectomy or removal of the ovary related to the ovarian cysts. So the diagnosis, the gold standard is laparoscopy. It requires seeing the endometrial glands, and we send any tissue that we excise to pathology. We take a very careful, systematic look up by the diaphragm to look for any areas of endometriosis there, by the appendix, anterior and lateral to the bladder, in the posterior cul-de-sac, underneath the ovaries, in the ovaries, by the fallopian tubes. If a patient desires future fertility, soon after surgery, we'll often evaluate the tubes with chromopertubation, where we'll check and inject dye in the tubes to make sure that they're patent. And then, as I said, the nice thing about laparoscopy is then we can also treat any lesions at the same time. In adolescents, the findings can be much more subtle. They can be clear vesicular lesions. They can be just slightly hyperemic lesions. So any lesions that we see, we'll always sample them and biopsy them, because even if they don't look classic for endometriosis, it can still be diagnostic when we excise them. And so that I think is one thing that's a little bit unique to the findings at the time of laparoscopy. And then after laparoscopy, if we've diagnosed endometriosis, we usually recommend continuing hormonal treatment. Studies show that the post-op recovery, the pain associated post-operatively is improved if they're taking hormonal medications or continued treatment after surgery. The first surgery is the most important and tends to have the highest benefit. If patients do have symptoms that recur, I like to think about all of the other treatments that we can think of, because each time someone has a subsequent procedure, the improvement of their pain is smaller than it is after the first. So minimal to moderate endometriosis patients will have 70 to 80% improvement of their pain. After a subsequent surgery, it can be as low as 30%. There are, as Rita had referred to, there's a lot of Facebook groups that can help for create a community for patients. There are also these other sites that are available for patients, and some of them are more focused on adolescents too. So I think that can be really beneficial as well. As I mentioned here, we have a multidisciplinary endometriosis center, And it includes gynecologists, the pelvic floor physical therapists, integrative health, colleagues in GI to evaluate for any GI conditions, and also if a patient has deep infiltrative endometriosis into the bowels, colorectal surgery, urology, as they sometimes have deep infiltrative endometriomas that endometriosis that invades into the bladder, or also if they have concomitant interstitial cystitis, which is also quite common. Pain medicine is great and can also offer nerve blocks as well as consultations to help with medications for treatment if NSAIDs and hormonal medications are not adequate, or if we want to either consider additional medications, multimodal treatments, or nerve blocks, which can also be quite beneficial. Sometimes we need to treat them with nerve blocks and things like that so that they can actually get to a place where they can do pelvic floor physical therapy. Because sometimes their pain is so bad that they can't really even start with the physical therapy because there's so much muscle tension there. And then pain psychology is within the Department of Pain Medicine. And so they can help quite a bit with coping techniques and addressing pain and kind of addressing catastrophic sizing of pain. So what we wanted to bring up in addition is that we have been thinking about an adolescent endometriosis center. I think that it would be great to be able to work with the pediatric colleagues that would be interested in endometriosis. And it doesn't mean necessarily that you have to have expertise in endometriosis, but if you see a lot of patients or you're interested in being involved in a multidisciplinary approach for adolescents, I think that this is a place where we could really work together and think about ways to help treat our patients and provide the best care for them. And so it took time to work on a model for the endometriosis center in general, to have the radiologist, pain anesthesia, pain psychology, integrated medicine all available for the patients. And it's really mostly a virtual multidisciplinary center, as we're all housed in our different places. But for example, with our colleagues in radiology, we meet with them regularly twice a month and go over cases together, and then invite other colleagues as well to review challenging cases or to review the images together. So from the perspective of adolescent endometriosis, this is partly within your expertise, so I'd be open to what your thoughts are on this, but perhaps adolescent pediatrics, I'm not sure if there are any pediatric pelvic floor physical therapists or physical therapists that would like to focus specifically and doing more pelvic floor with adolescents, integrative health, pediatric GI, pediatric urology, pediatric pain medicine, and pain psychology. I think that in pediatrics, there are a lot of really great resources to help with chronic pain. So perhaps that could be a helpful area for endometriosis as well. So if anyone is interested or you have suggestions, my email's there, and I would be happy to start working together along with I'm the associate director for the Center of Endometriosis. Dr. Opoko Anane is the director, and both of us are really excited about potentially developing an adolescent endometriosis center. So if that's something that you would be interested in, I'd be glad to talk about that further too. And that is basically the end of our talk. I have a few references here, but I'm going to leave up this slide just in case so that you have my email as well. But thank you so much for your time and attention. And we just wanted to open it up to questions.
I also, if it's okay, wanted to just really quickly say thank you so much first to Dr. Lager, who has been such an amazing mentor to me, and I've learned so much about endometriosis from, but also to the pediatrics department here at UCSF. Thank you so much for having us. I've met so many amazing pediatricians here, and it's because of the passion and commitment to patient education that I can even be here today. So I just really wanted to thank you for this opportunity. Yeah.
Thank you both for this outstanding talk and so much good information for all of us, I'm sure. If there are any questions, please put them in the Q&A function, and we will monitor that and see. We have some time for questions. I think I'm going to just start by a question for Rita. Rita, how has this experience informed how you think about your future career in medicine? Do you want to tell us?
Yeah, of course. So I think that this has very much informed my future career. Before I had the surgery, to be very honest, hadn't really considered OBGYN. Granted, I wasn't in college at the time, so it was a bit early, but I'd really always been interested in the brain. And after this experience and learning how many, from my own lack of information with regards to women's health and learning how common this was and how I could be a part of this, it's been incredible. I think it's totally changed my mind and my track of what I care about and who I want to help. Yeah.
And we have a comment on the Q&A that just says, thank you for this talk. But no questions yet. So I'm going to just take the liberty to ask you another question, and that's probably for both of you. I'm sort of hearing that there are some generic lessons here about how to engage patients in their care. Any words of wisdom, maybe in particular for this age category of the young adolescents category that come out of your experience as a patient and as a provider?
Dr. Lager, I'm not sure if you'd like to start us.
Sure. Yeah, I mean, I think one of the things that's important is as you're talking to the patients and finding out how school is going is, to help them connect with people at school so that if, for example, they have pelvic pain and they can come in and have a place where they can rest or take a break, and work closely with the nurses for that they may need intermittent breaks in school. I think that trying to support the students so that they can be in class as much as possible and not missing school can be a big part of it. And then the other part is just talking to them about the different components of the pain to help patients understand that doing one thing alone, one treatment may not adequately manage their pain, but doing the combined group of treatments can help. And then the other thing I think that is important is that anytime someone's had pain for a long period of time, it does not go away the next month with treatment. Usually it takes time. And so I try to mentally prepare them for example, physical therapy usually takes 3 months before they start to see a dramatic benefit. And so I think that part is really important. And also close follow-up. So follow up perhaps every 3 months to make sure that whatever you're recommending, even if it's starting out with NSAIDs, that it's working adequately for them, that the patient doesn't have any other questions, and to kind of provide a space for, especially for adolescents, as if they're changing their practices or if they're going to start becoming sexually active, that we can kind of think about their pelvic pain and dysmenorrhea along with what their goals are with regards to contraception.
Great, thank you. Rita, did you have anything to add to that?
I think that was amazing. I really liked the idea Dr. Lager had mentioned earlier about keeping a diary. I know, to be honest, personally, I would have probably been very bad at writing things down, but I think it was actually a pediatrician here who had mentioned that there are many apps like Clue, and I'm forgetting the names of some, but since we're always on our phones nowadays, I think that's a really cool opportunity for kids to be like tracking things as well. So yeah, that was the only thing I'd want to put out there.
A couple of questions came through the Q&A. So one of our pediatricians actually asked, she saw a 17-year-old today with pelvic pain, acyclic and cyclic, and wondered if I should or should not have ordered ultrasound. Do you have enough information there to give a judgment?
I would say, depending on if they're cyclic and acyclic, the couple things that I would think about is just making sure that they're not related to bladder or bowel, that it's not appropriate for them to be worked up for IC or for IBS. I do think that if they've had persistent pain that's brought them to you, that they've probably been having it for a while, and it may be beneficial to order some imaging. And then, the ultrasound, if the patient's not sexually active and they're lean, usually I think that they can often see most of the organs, even with a transabdominal ultrasound. Without a transvaginal ultrasound, that becomes a little bit more challenging with increased BMI. But I think that depending on what your level of suspicion is, I think it's reasonable to get the ultrasound. If you have a really high rate of suspicion for endometriosis, especially that they might have, rectal lesions or something that's deeper, then I think that it can make sense also to order an MRI. And the MRI that we order is MRI female pelvis, because rather than MRI of the pelvis, because then that enables the radiologist to do an endometriosis protocol where they ensure that they get all of the areas that they're focused on looking at. So that would be one other piece of information. So I'll always order MRI female pelvis. And then the other thing I would say is that sometimes when we order imaging, if we order an MRI from the outset, it doesn't always get approved, and insurance companies do sometimes request that the ultrasound needs to be done first. And I think that's a balance of the limitations, what you're expecting to see or we have a high index of suspicion for. Because it may be that the MRI is more beneficial than the ultrasound. So just to keep all of that in mind.
Another question here is very practical. Who at UCSF is doing adolescent gynecology? Sounds like you do, Jeanette. Do you have colleagues, like names of people who do this? Is there a special center or?
Yeah, so unfortunately, we do not have an adolescent gynecologist here at the moment. Both Dr. Opoko Anane and I do adolescent endometriosis. Dr. Kamali does some adolescent gynecology as well, but we don't currently have a dedicated pediatric or adolescent gynecologist.
And then another question here, what would you suggest for treatment for patients with contraindications to hormonal birth control?
Mm-hmm. So if it's a contraindication to just estrogen, then I would do a progesterone only medication. I think that the mainstay is to try to suppress periods and create a hypoestrogenic state, or even with a high dose progesterone, it can also help to improve those symptoms and atrophy the endometriotic glands. If they can't take hormones at all, usually they're not contraindicated to a GnRH antagonist or agonist. But if they can't take any hormones at all, then we can also just do pain medications, so the NSAIDs, and then consider gabapentin as well, although that can cause a lot of somnolence too.
And then this last one is not really a question, but perhaps something that you can comment on. Someone saying, I had a patient getting pelvic physical therapy, including biofeedback at the UCSF Cancer Center for Pelvic Physiology. Any experience with that, comments on that?
Yeah, so our pelvic floor physical therapists are one where they see patients both at Mount Zion and at Mission Bay, and they will often do a combination of biofeedback as well as pelvic floor physical therapy. And then there are a number of people that are outside of UCSF in San Francisco and in Northern California, the greater area. So we will send patients referrals to many different places that are outside as well, but that they specifically focus on pelvic floor physical therapy. And that usually does include sometimes biofeedback, because they'll often, if patients have a lot of pain, start with the relaxation techniques, and sometimes also vaginal dilators, depending on their pelvic pain as well, so they can help them with those as well.
Great. I think that is the last of the comments and questions in the Q&A. So I'm gonna let people go 5 minutes early. It's always nice to have that 5-minute extra break if you get it. And thank you both for this great presentation, for joining us here in the Department of Pediatrics Grand Rounds, and wishing everybody a very good rest of their day. Thank you very much.
Thank
you.